would like to share with you a couple of case examples and also maybe fire up the discussion when to use which strategy or which device. So obviously the decision making should be based on the entry tier. So if the entry tier is only affecting the ascending, then obviously a limited procedure can be justified, whereas the arch is affected. I guess we need to do more aggressive procedure. So this is the first example. So whenever we see a patient that has an isolated tear in the ascending with or without malperfusion, our standard approach would be to use the open anastomosis and as an adjunct the AMDS stent. However, unfortunately, not all cases are that easy. This is an example where a tear is in the distal arch, as can be seen here in the angioscope. And so in those cases, the AMDS is not going to work. You need to exclude the entry tier, and this can only be done by using a full arch replacement. Typically, we would go for a frozen elephant trunk procedure in those cases. Then there's another group of patients that is highly debatable, obviously. These are those patients that might only have a tear in the ascending. However, they're either very young and or have a suspected connective tissue disease. And in those patients, we are quite aggressive and would also go for a kind of prophylactic arch replacement using a frozen elephant trunk, but I'm fully aware that this is debatable. So let's have a look on a couple of cases. This is a standard type A, an easy one, so to say. Ascending has a tear, no arch tears, no malperfusion. So standard treatment would be the open anastomosis with a zone 0 AMDS stent. This is a similar case. Again, only a tear in the ascending, no arch problems, no cerebral malperfusion. However, distal malperfusion, in this case, the left leg was gone, but the algorithm will not change. Open anastomosis plus AMDS zone 0 stent should solve the issue, and the left leg nicely opened up as it can be seen on the CT post-op scan here. Now things get a little bit more complicated. Again, tear only in the ascending, no arch tear. This time again malperfusion, but affecting both carotid arteries. So whenever the carotid arteries are affected, we think it's critical to discriminate between whether or not there is false lumen thrombosis. And this can be nicely done by intraoperative Doppler, as can be seen here. Yes, there is a compression of the true lumen. However, there's no thrombosis in the false lumen. And in those cases, no additional procedures are required. Just do your standard open anastomosis with the AMDS stent, and everything is nicely going to open up. Again, carotid involvement, but this time things are much more complicated. First of all, we have an arch tear, which means we would need to do something to the arch. Then we have severe cerebral malperfusion with complete occlusion of the right-sided carotid. And this time the Doppler shows complete thrombosis of the false lumen. In those cases are very unlikely to open up without further intervention. In addition, we also had an occluded innominate artery, which kind of requires a change of perfusion strategy. So in those cases, we would openly expose the carotid bifurcation. In this case, it's the right side. We will then cut the internal carotid, ligate proximally, and then do an end-to-end 8 millimeter graft anastomosis to the internal carotid artery. And this is then followed by the insertion of a 16 French cannula through the graft directly into the carotid artery that can then be snared to avoid bleeding. And then this is hooked up to a separate pump to ensure right cerebral perfusion. And obviously then during the rest of the procedure is done through a femoral artery initially, and then through an antiflow graft once the frozen elephant trunk is in place. This is the final CT scan here. We used the Evita Neo in a zone 2, the branched version, the extra anatomic right internal carotid through the graft as shown, and in addition, an extra anatomic right axillary artery revascularization and a biological root. So this is basically the exact same case. We have cerebral malperfusion, complete occlusion of the right carotid, as well as occlusion of the innominate artery. But and also again with false lumen thrombosis, so we need to do the modified perfusion thing with end-to-end to the left-sided carotid, right-sided carotid. Sorry, so the exoanatomic. However, there was no primary tear in the ascending, and also there was no real arch tear, and also there was no suspected connective tissue disease or polyaneurysmatic aorta. And this is why in this case we decided to do zone 2 AMDS, but then not a straight, but rather a branch surgical graft to house the exoanatomic right carotid, as well as end-to-end to the left and the innominate. And the root was repaired using a sandwich technique in this case. So you can see that there are many different scenarios, and either an AMDS plus an open anastomosis or a frozen elephant trunk might be the treatment of choice. I guess very critical is the situation where you have complete occlusion with false lumen thrombosis of one of the carotid. And in our opinion, selective perfusion through an end-to-end anastomosis of the carotid should be considered in those cases. So again, to summarize, basically, the algorithm is based on the entry tier location. I think this is obvious. Whenever there is only the ascending affected, and this is 80% of the cases roughly, then the AMDS is going to work very well as an adjunct to the standard hemi-arch. However, if you have a tear in the arch, it simply needs to go either with a classic or frozen elephant trunk technique. There is that debatable younger subgroup of patients or those with suspected connective tissue disease that some groups, including ours, would advocate a prophylactic frozen elephant full arch. However, summarizing our experience so far in the type 1, type A acute setting, we have implanted 85 frozen elephant trunks since 2015, but this is only divided under 5 trained surgeons. In contrast, the AMDS is very popular in our institution, 75 implants since 2018. And this is divided by 11 surgeons. So basically, this is highlighting again that the AMDS is a completely different ball game than a complete frozen elephant trunk arch replacement. And the learning curve is super steep and therefore very well suited for the emergent setting at night.